Now move to the next lecture. And this is again, as I said, it's a pride to invite my own teacher, Dr. Ingalhalikar, whom I trained as a resident in Sion Hospital. Dr. Ingalhalikar in the spine circles needs no introduction. He was the founder of the Association of Spinal Surgeons of India. He has been the past president of the Association of Spinal Surgeons of India. And like the mentor, the father figure of that association, it has been because of him that the association has been there and moved up. He's also been past president of the Bombay Orthopedic Society. And what is similar between Dr. Tanna and Dr. Ingalhalikar is the number of extracurricular activities that they have. I mean, Dr. Ingalhalikar he writes Marathi poems. He has been awarded the Marathi equivalent of the Filmfare Award. He writes shairis, etc., music. All the anthems of the Bombay Orthopedic Society, the ASSI, the BSS have all been written and directed by Dr. Ingalhalikar. He's a fantastic musician and a skilled artist, sculptor, etc. So there is so much beyond medicine that he does and he's capable of. But today, there is a very serious kind of talk that he's probably going to give. And that has probably been initiated by my own experiences over the last 6 months or so. And when I discuss with other seniors like Samir, Arvind, etc., and we notice that the number of patients coming to us with complications following spine surgery has dramatically increased. And I thought it would be a nice time to wake up all of us, including the youngsters, by my talk for him was the spine surgery, the need for restraint. He decided that would not be the most appropriate talk, and so he's modified it a little bit. And I would like to invite Dr. Ingalhalikar to come up on stage, sir. The podium is yours.
Am I audible?
Yes.
Well, good afternoon, ladies and gentlemen. It's a privilege to stand here and voice out some of my concerns about what's going on in spine surgery. Skip this. And I've titled it, Spine surgeons, hold on, please show some restraint. First of all, let me say this very, very strongly, that the spine surgery has a strong, legitimate, undeniable place in patient's care. There's nothing to dispute about it. So I'm not standing here to oppose spine surgery. I'm not against spine surgery. I love spine surgeries. I'm proud to be a spine surgeon. I still participate in spine surgeries. I advise surgeries. But if you ask me, am I also happy today after so many years of that? Generally, yes, but not always. I feel sad, ashamed, hurt by many patients' comments. It happened to me when I was young. It happened because of my own mistakes, because of my own doings, and because of other people's doings. It is happening even today, not so much because of my doings, but others' doings, and it is gradually increasing, rather rapidly increasing. When I inquired with my other colleagues from other countries, even then and today, they have same concern. One of my patient's son called me up. I was on the airport leaving out for 10 days. And he said, I have back pain, I want to show you. I said, I'll be back after 10 days. In the meanwhile, go and see somebody around you. After 10 days, he came back, examined him, everything is fine. He was already functioning, driving every day 30, 40 kilometers. And he was even going to the gym. When I saw him, no findings, hardly anything. Small, tiny speck of edema at L4, L5 disc annulus posterior. Nothing more than that. And he did not take rest, did not take medication. So I said, you don't need anything. You go home. If at all you have trouble, take some paracetamol, you'll be all right after that. His grandfather, who was accompanying him, happened to be one of our senior consultants from Sion Medical College, was everything. He says, listen to his story further. This boy had gone to another spine surgeon who had told him immediate tomorrow morning emergency surgery. So he went away to another surgeon who again happened to be my student, and he told him, yes, you do need surgery. So his grandfather told me, is this what you teach your students? Is this what you teach your students? He also said, do these people belong to some gang who is out to earn money? Are there any mercenary gang? Imagine my plight in such a situation. At the time of going away, that grandson, gave me a printout of an article. This is the article. This is an article by Nancy Epstein, who's a senior neurosurgeon. She examined 183 second opinion patients in 20 months, and she found that the previous spine surgeons had advised or had done 60% unnecessary surgeries. 33 were wrong and only 6% were right. This is about second opinion, third opinion cases. In older than 65 patients, 40% unnecessary instrumented fusions were done. In many frail patients, overtly aggressive or on the other end, absolutely incompletely, insufficiently invasive surgery was done, and complication rates were very high. This trend is not new. Right when I joined Sion Hospital, way back in 1973, I found this. It's a universal phenomenon, but it's very, very rapidly increasing. During last 6 months alone, I have seen 21 patients of unneeded spine surgery. Of these 21, 9 were operative, 12 were advised surgery, and amongst those 6 surgeries, 9 people had failed surgeries. Amongst those 6 failed surgeries, 3 were people with very severe yellow flags, severe depression, schizophrenia, paranoid, etc. So without regard to them, they were operated upon. And something more shocking, nearly 30% said that no clinical examination was done. Only MRI reports were read. Sometimes films seen. Patients were not touched. This is today's reality. People like Dr. Tanna and me, we go home and we cry. It's an omnipresent phenomenon. It's not present only here. It's everywhere. We don't understand magnitude because we don't believe that we are making mistakes. We don't believe that we can be unfair. We never declare that we do wrong surgeries. There's a dismal absence of well-maintained records with all of us. In India, we also have no unified medical system. On one end of the spectrum, we have very expensive corporate hospitals. The other end, we have mofussil-free camps and all stages in between. Where is the quality control? Where's the record keeping? Where's the patient screening? Who controls? Who monitors? There's nothing. Anybody will do what he wants and what he feels is okay. I came across in a very interesting article by Brownlee in Lancet 2017. They have called this as a 60-30-10 rule of unnecessary care. They studied all specialties of medical field, variety of settings in UK, USA, and Australia, and they found that approximately 60% healthcare is of value and keeping up with guidelines. 30% of low value, they were duplicative or even unnecessary, and remaining 10% were decidedly harmful things were done. Dr. Bernard Long was a pioneering cardiologist. He was a Nobel laureate also. He was a philanthropist, doing a lot of social work and a lot of patients' care. With like-minded 10, 12 people, amongst whom there was one Dr. Vikas Saini, orthopod from USA. They formed what is called as Sloan Institutes in Needham. The institute's purpose was to US medical care system, which was deteriorating. They want to make it patient-friendly. They want to make it just. They want to make it correct. And they advocate minimizing unnecessary care. They want to stop all mistreatment, maltreatment, wrong treatment, under-treatment. They do a lot of research work, they do clinical programs, they do conventions, etc. These people studied Medicare databases for unneeded spine surgery. I call that USS. And they found that 2019, 2020, 2021, in 3 years, that over 2 lakh unneeded surgeries were done. It's not a small sum. I didn't believe it in first. I repeatedly read that. And they are very firm about that. Costing approximately 2 billion. Very often they were performed without clear indications, and many faced risks like infections, DVTs, and postoperative neural loss. They have selected hospitals where more than 500 cases were done every year. Then they have total procedures, overuse procedures, and overuse rate. Sorry. I have purposely not given the long forms of the hospital. MNMC, Pennsylvania, 535 cases done, 336 were unneeded spine surgery procedures, making it 62%. What is surprising is out of those 336, 308, 92% were done by one single surgeon setup. You can see the way unneeded surgery is being. Then you have all these other hospitals, 42%, 40%, 40%, 40%. Another set of 5 hospitals, 39%, 39%, 38, 37, 30%. Friends, till 2 days ago, I did all the internet search. I used 4 AI engines for searching also, and I did not find a single lawsuit or hospital spine surgeons initiated litigations against Sloan Institute. If that says anything about its authenticity or of the truth in it. How can you explain the variations at various places so much? I'll tell you my own experience. 1977 to 78, in my department, orthopedics, we did only 16 interbody fusions over 2 years, while my own neurosurgery colleague did 38 interbody fusions in those 2 years, under same demographics, same patient population. Well, this is not uncommon. You find Mayo Clinic has 20%, San Diego 1%, Cleveland Clinic 1%, unneeded vertebroplasties. Talking about spinal fusions, 18% unneeded done in New Hampshire, Pennsylvania. There's a paper by Weinstein which found that per capita spine surgery count in US is 5 times higher than in England and Scotland, and 40 times higher than 12 other developed countries. There's another paper by Schoenfeld in Clinical Orthopedics. They came to the conclusion that preferential use of interbody fusion is fee for service, commonly done compared to fixed surgeon salary models. There's another paper by Bayer from Germany, and they found that the competition between hospitals appears to lead to increased spine surgery rate. It doesn't end there. There's a paper by Nora McCready, and they said 2,000 MRI requisitions, out of them, more than half requests were for inappropriate reasons or were not indicated at all, or when they were of no value. The second paper, again by Webster, it says early MRI within 6 weeks of low back pain onset doubles the likelihood of spine surgery. Even when there are no red flags, surgeries are being done. Another paper by Lurie, regions with higher MRI use for back pain have higher spine surgery rates. There's, to curb all this, a lot of people have done a lot of initiatives. AAOS is one such body, along with a couple of things. They do what is called Choosing Wisely campaign. And they have advised no MRI in patients with non-specific low back pain and no red flags, because that leads to unnecessarily interventions, including surgery. These are authenticated statements coming from this. There's a paper by Hovis. He says, we don't do RCT of our surgical procedures with non-surgical alternatives. We never do RCTs with them. And they found that far more number of medical interventions are RCT based, RCT compared, than most surgical procedures. We don't like to do with them whether it can be done in any other way. Are we unaware about this? No, we are not unaware about this. There is a survey done by Liu, survey of 2,100 practicing physicians in USA, and 70% of them said that they were aware of this and they believe that doctors are more likely to perform unnecessarily procedures when they profit from them. This is again fully authenticated paper. Well, is this the side? Is this everything that bad? Are we all so greedy? Are we all such a big, huge money mongers? I ask myself, am I that bad? Is my community that bad? And again, I tried to search as to why. Are there any other reasons? Yes, there is a softer side to it. There is perhaps. We have what we call biased perpetuation of values. Most of our procedures are coming out, or they're published, or they are presented depending on observational evidence alone. No comparison, no RCTs, nothing. I see a procedure presented here today, and then I start doing it. I do another procedure to make it better. I do something to make it better. I try to improve the implant, but I never ever think of doing a paper comparing that procedure whether anything else can be done. I only perpetuate that belief by doing work on those directions, never in any other direction. These are the papers. There is a paucity of comparative studies in spine surgery literature. My experience is when you search spine surgery journals, the papers concerning non-surgical treatment are absolutely sparsely seen. I do not know whether there is any at editorial level bias in accepting or not accepting. Cognitive behavior science tells us so many things about this. This is a paper by Tunis, and it says that lack of evidence, lack of understanding, or unawareness of evidence leads to uncertainty. We as surgeons have been always told कि कुछ uncertain नहीं रखने का. You have to be very definite in your management. And therefore, when we are uncertain, we often resort to surgery. Because surgery is something which is certainty. There's a paper by Harris, it's a book by Harris in Australia. The book is titled Surgery, the Ultimate Placebo. He says spine surgery is done, patient is better, therefore we believe that improvement is due to surgical intervention. There's something called fallacy after this, therefore because of this. We surgeons become victims of this fallacy. You have to remember, in many chronic pain patients, even when you do wrong level surgery, patient is still better. So the source of pain was not what I addressed. And they are going to be naturally improving. There's something called placebo effect of surgery. All chronic pain patients getting treated over years and years, you change their blue capsule into yellow tablet, they feel better for a few days. Instead of this physiotherapy modality, you give this therapy, for a few days you feel better. Similarly, they have what we call placebo effect of surgery. I open up something, I find nothing, कहाँ तो खुचुर खुचुर कर देता हूँ, and I come out wondering, कुछ तो किया नहीं मैंने. And the patient next day greets me with big smile, Sir, मेरे को जिंदगी में अच्छा नहीं लगा, ऐसा आज अच्छा लग रहा है. Only to tell me after 10 days, Sir, I am worse than before, I am where I was. Now this is a known phenomena. Another paper by Nickerson, there's something, various biases we go through, what we call optimism bias. The tendency to overestimate good things and underestimate all the negative outcomes. There's other biases also. I've done few cases last week and 2-3 weeks before that. Both patients have done well. So I'm biased now. अभी इसको भी वही करेंगे. अभी अगले patient की भी वही करेंगे. So we have, this is what is called availability bias. Even when it comes to searching something, I come across something or I form an opinion, I would search only what is positively supporting that. I would think about it, I would search about it, I would relocate about it, rethink about it, recall about it, only something to support what I'm already feeling. During training, most of us learn to do cases without questioning any evidence or whether that is required, not required. With the result, people learn to do, this is how it is to be done. I met two young neurosurgeons. They said, Sir, हमको कभी सिखाया ही नहीं कि this can be treated non-surgically. Because we never ever treated it non-surgically. This is what we learned. Well, you can't blame the guys. There's something very important called social nature of surgical practice. The surgeons, they tend to do what other surgeons are doing. So it's the belief of a group that we believe in doing so and so thing. So my colleagues in my hospital will try to do exactly same thing. ये 4-5 लोग ये करते, चलो मैं भी कर लेता हूँ. Without questioning anything, this is what is being done. 20 years back, I went to a small town place medical college and I demonstrated PA life there. Immediately I was approached by a young surgeon who had passed his MS 1 month ago. He said, Sir, can next month, I'm coming to Bombay for 2 days for my friend's wedding. So Saturday morning for 2 hours I'm free. Can I come to you and learn PA life? I said, do you have experience of spine surgery? He says, no. I said, why do you want to learn PA life? Sir, I'm mostly getting appointed as lecturer and I want to do series in spine. We see surgical demos and we immediately want to go back and perform them. without thinking of rationality of that demo, need or no need of that, we just want to go and do that. It's very sad thing that most of our meetings, conferences, workshops essentially revolve around only surgical techniques and technology. All of us know that when we treat axial spinal pain, back pain, neck pain, etc., surgery is needed in less than 20% cases. We spend whole conferences on learning those 20%. Have we ever spent time on learning that 80% patient's management? The red flags, and red flags. We use red flags. They are screening tools. They are not to be used for decision making. They are non-specific. We overvalue them and we base our surgical indications on red flags. We grossly undervalue yellow flags, depression, schizophrenia, all psychosomatic problems. And we operate upon patients and we come across failed surgeries in so many of them. Are absolute indications for surgery really absolute? You will find scores and scores of patients where this is true. This is my MRI, my myelogram, 1987, when MRI was not available. I had acute ruptured disc L5S1, pain, spasm, tilt, SLR positive 20 degree. My L5 was grade 4, my my S1 was grade 3. My daughter was going through renal dialysis and she was scheduled for renal transplant within 10 days. I could not undergo surgery. Over next 2 years, I recovered completely to the extent of doing Himalayan treks, doing small marathons, doing all physical activities and playing badminton and volleyball. I was an absolute indications for surgery. Every patient can be a surgical patient. One can always convincingly create a need for surgery. Surgeons, especially young ones, they declare that I'm a spine surgeon. I'm endoscopic spine surgeon, and then they want to justify their existence by performing those surgeries again and again. Anything that comes their way, they will do it. I was also sad when I heard one of the junior mentors telling his trainee, 6 महीने में तुमको हर महीने 10 से 15 सर्जरी करने का ही है, नहीं तो तुम स्पाइन सर्जन नहीं हो. What kind of a training a mentor is giving his trained surgeons? I have some concerns. I will just say, this is something I have experienced over years. A busy surgeon, no scheduling available for 15, 20 days. 20 days are full for surgery. He tells his, आज परसों जो कुछ लोग आएंगे ना, उनको सबको non-surgical treatment दे दो, irrespective of what they are, because we are busy for coming 20 days. After 4 days, one patient cancels the surgery. एक patient को phone जाता है. We went through your records, and for a second thinking, we think you need surgery. Please come back. So you are conveniently doing or not doing. I feel bad when surgeons operate like business models. Hurry up, otherwise patient will recover. I must earn XYZ amount of money per hour. Some people even work on the terms that so many kilograms of implants per month. I wonder whether their lifestyle depends on that. Are we responsible for bringing disrepute to spine surgery? All 10 patients whom I would advise surgery, first ask question, sir, can we not do this without surgery? We don't want to undergo surgery. Are we bringing this reputation because of us? Are non-surgical spine care setups thriving because of us? Can we do anything about it? Yes, there are a few things we can do. One is we must encourage patient for more opinion. I tell patient, well, I give you my opinion. If you want, you take more opinions and decide what you want to do. In my group, Dr. Prabhu, myself, and Dr. Chaube, three of us worked together. And every patient was discussed by three of us together and then operated upon. I think that is something which is very important. My advice or my wish is that BSS, MISAB, all such bodies, ASSI, they must either form an initiative like North American Spine Society, Choose Wisely campaign, or some such thing, where such things could be avoided, could be kept aside, etc. At the end, I would like to give a little piece of advice to people. If you want, you can call that as a Dr. Ingalhalikar's dictum. When treating back and neck pains, first be a physician. Pause and think, can I do anything else? And be a surgeon only afterwards. Friends, some of you may be like first figure, smugly smiling and happy that somebody brought this out. Somebody must be controlling themselves. Sir ne kyun ye baat kiya? I hope I have not created a guy who's a dagger drawn because I spoke all this. Well, once again, I thank Dr. Javeri and all BSS executive for inviting me. It's really honor to be giving this presidential oration. Namaste.
I like the presentation and congratulate especially for the young surgeon like me. We did a study, we figuring out the role of obesity, lifestyle, insulin resistance.
Yeah, so many things are there.
And
See, I had a
publish it.
limited time to talk.
We publish it and we figure it out that what's called non-specific back pain could be specific back pain due to this problem. Yeah. The problem that's with the definition, because whenever you read in the textbook that 85% is non-specific, so go take non-steroidal Panadol and go with exercise and they will never, let's say, improve. And after that, they will ask for the surgery. But my concern that's, do you recommend, let's say, your MRI for the young generation to treat as a conservative treatment, although you presented with a weakness?
Yeah, the patient, I would decidedly do the complete investigation. I would come to the concrete pinpoint diagnosis. Then taking into consideration all the factors, everything put together, I might advise him to wait and observe him.
Even he has a weakness?
Yeah, there are patients with weakness whom I make to wait. Suppose a patient is a severe cardiac patient. He's unfit for surgery. What will you do? You will treat him, and if he shows recovery, a youngster who's otherwise bulky, healthy athlete, I didn't have time to say, one of the patients who's an athlete, I saw him in last August with a ruptured disc with neurodeficit. I told him, go easy. In that month of December, after 4 months, he did 52 kilometers of marathon. I told him, go easy. He didn't listen to me. In the 1st June, 1 month ago, he did Ironman, which includes swimming 3.2 kilometers, cycling 120 kilometers, and running. He did that in record time, ruptured disc August with neurodeficit.
So the message here is that
Don't be in hurry.
Yeah, we
I'm not
all
against
agree.
surgery.
We all agree. Now, for all my patients, I'm not hurry, but if I receive a patient with weakness and foot drop, I will never wait. This is my concern.
so there is a difference between a functional neurological loss and a non-functional. A lot of the times when we see the reports of people having seen a patient, you get a EHL grade 3 weakness. Now that patient has not realized he has an EHL weakness. You told him he has an EHL weakness.
No,
because
you,
this
I'm,
He
I'm
is
talking
fully
about
functional.
our examination, not to deliver.
Yeah, so if that is and you have to differentiate between pathology. Now, if it's a functional, non-functional neurological loss, probably you don't need to rush into surgery. You can wait. He may recover.
Yeah,
The second
ultimately
thing
it all
is that
depends.
disease. Now, if you have a lumbar disc prolapse and a deficit, it is probably very high chance that it will recover. The same if it's a lumbar canal stenosis may not recover because it's a slowly progressive problem over
Yes,
which
your
is-
judgment matters.
Yeah. Thank you.
Thank you.